Dear viewers, welcome to Essentials of Acute Care. I am Dr. Sunil Garg. In this video, I am going to discuss about mechanical ventilation during prone position. I will be covering all the relevant aspects of this topic. Prone ventilation refers to the delivery of mechanical ventilation in prone position. It is important to understand that it is not a different mode of mechanical ventilation. It is used in the management of ARDS as a strategy to improve oxygenation when lung protective ventilation is not effective enough or fails in supine position. But how prone position helps in achieving improved oxygenation? Prone position alters the mechanics and physiology of gas exchange by ameliorating the ventral dorsal transpulmonary pressure difference, reducing dorsal lung compression by heart and diaphragm, and by improving lung perfusion. Changes in the distribution of extravascular lung water and secretions may also play a role. I will discuss each aspect of mechanism which helps in improving oxygenation individually, but before that I will go through a diagram representing distribution of aerated lung in a spontaneously breathing patient in supine position. Here we can see the diagram. This is sagittal section of lung in supine position. This is anterior-posterior axis and this is cephalocaudal axis. This is open part or the aerated part of the lung. Hatched part is the poorly aerated lung and the closed or the black part is the non-aerated lung. This is the distance from the anterior chest wall to posterior chest wall, and this is the distance from apex of the lung to the base of the lung. Here you can see as we move from the anterior to posterior direction or from apex to the base of the lung, the aerated lung decreases and non-aerated lung increases. It means when we move from the ventral portion of the lung to the dorsal portion of the lung, the aerated lung decreases. In the same way, when we move from the apex of the lung to the base of the lung, aerated lung decreases and non-aerated lung increases. Now coming back to how prone position helps in improving oxygenation. The first important mechanism is reduction in ventral dorsal transpulmonary difference in prone position. In supine position, there is a greater expansion of ventral alveoli than the dorsal alveoli. In ARDS, this effect is exaggerated. The difference between ventral and the dorsal transpulmonary pressure appears to be favorably affected by prone position, making ventilation more homogeneous, leading to a decrease in ventral alveolar overinflation and dorsal alveolar collapse. By this, prone ventilation recruits alveoli that limits ventilator-associated lung injury from overdistension and cyclic atelectasis, hence improved ventilation and oxygenation. Secondly, in supine position in ARDS, dependent lung collapse by heart and the diaphragm may exacerbate increasing hypoxemia because of worsening shunt due to collapse. Prone ventilation reduces lung compression by both the heart and the diaphragm, and these effects improve ventilation and oxygenation. Third important mechanism is improved lung perfusion. In ARDS, there is substantial ventilation perfusion mismatch in the supine position, since blood flow and the alveolar collapse are both greatest in the dependent portion of the lung. In prone position, as the previously dependent lung continues to receive the majority of the blood flow, independent of the gravitational gradient as alveoli reopen, while the newly dependent lung continues to receive the minority of the blood flow as alveoli begin to collapse. Additionally, increase in cardiac output have been observed in prone position and thought to be due to the effect of increased lung recruitment and reduction in hypoxic pulmonary vasoconstriction. Now we will understand it through an image. Here you can see an image. This is in supine position and this is in prone position. This is axial view of lung and this is sagittal view of lung. Here you can see transpulmonary pressure across ventral region of the lung and the dorsal region of the lung in supine position and in prone position. And here you can see the blood flow in supine position and blood flow in prone position. You can see here this alveoli in the ventral region of the lung is overdistended while in the dorsal region of the lung is collapsed. When we make the patient prone, the earlier collapsed alveoli becomes reopened and the overdistended ventral alveoli becomes less distended or normally aerated. This image represents the changes that occur as a consequence of prone position compared with supine position. Distending pressure of lung is determined by the transpulmonary pressure. When an individual is supine, the ventral transpulmonary pressure significantly exceeds the dorsal transpulmonary pressure, resulting in greater expansion of the ventral alveoli than the dorsal alveoli. This effect is exaggerated in acute respiratory distress syndrome such that ventral alveoli become overdistended and dorsal alveoli become atelectatic. Prone positioning reduces the difference between the dorsal and the ventral transpulmonary pressure, making ventilation more homogeneous, leading to a decrease in ventral alveolar overinflation and dorsal alveolar collapse and recruitment of alveoli that had collapsed during the supine position or supine ventilation. In ARDS, there is a substantial ventilation perfusion mismatch in the supine position since blood flow and the alveolar collapse are both greatest in the dependent portion of the lung. When prone, ventilation perfusion matching improves since the previously dependent lung continues to receive the majority of the blood flow as alveoli reopen, while the newly dependent lung continues to receive the minority of the blood flow as alveoli begin to collapse. Regarding efficacy of prone ventilation, most trials demonstrated improved oxygenation in most patients with ARDS. Up to 70% patients increase in the PaO2 allows a reduction in the FiO2. Most patients who are favorably affected shows response within the first hour. In addition to improving oxygenation and reduction in the delivered oxygen concentration, the available data suggests that prone ventilation reduces mortality in patients with moderate to severe ARDS, means PF ratio is less than 150 mm of mercury, who are managed with the low tidal volume ventilation. Although poorly studied, the following factors may predict improved oxygenation during prone ventilation. So, if patient has any one of these factors, it is likely that patient will respond favorably to prone ventilation, and these factors include patients with diffuse pulmonary edema and dependent alveolar collapse, patients with an extrapulmonary cause for their ARDS, patients with elevated intra-abdominal pressure, and patients whose chest wall compliance decreases when moving from the supine to the prone position. Prone positioning does not appear to consistently benefit those with mild or moderate ARDS. In terms of indication of its use, it is indicated in patients with moderate to severe ARDS, means when the PF ratio is less than 150 mm of mercury on oxygen 60% or more and PEEP 5 or more, who fail to improve in supine position despite use of lung protective ventilatory strategy, provided there is no contraindication. Or it can also be used in patients with ARDS who have refractory hypoxemia, that is defined as PaO2 or partial pressure of oxygen 60 mm of mercury or less on FiO2 of 1, or as a bridge to extracorporeal membrane oxygenation. Regarding contraindication of prone ventilation, it is divided into absolute and relative. Absolute one includes spinal instability or patients at risk of spinal instability like patients with rheumatoid arthritis, unstable fractures like fracture of facial bones and pelvic, anterior burns, patients with chest tubes and open wounds, patients with shock, pregnancy, recent tracheal surgery, and raised intracranial pressure. The relative contraindication includes hemodynamic instability, cardiac abnormalities like freshly placed pacemaker, life-threatening arrhythmias, ventricular assist device, and balloon pumps. In such cardiac patients, devices may be dislodged or immediate access for cardiopulmonary resuscitation may be needed urgently. Other categories include patients with thoracic and abdominal surgeries, difficult airway or difficult intubation, and patients with massive hemoptysis. Prone ventilation is not contraindicated in those who require vasopressors provided patients have a stable mean arterial pressure of 65 mm of mercury or more. Similarly, receiving renal replacement therapy through central venous catheter is not considered a contraindication with the exception of peritoneal dialysis. Procedure of prone positioning has many factors to consider. Regarding timing of initiation, it should be early, means after a 12 to 24 hour stabilization period of supine ventilation and up to 36 hours in the course of mechanical ventilation for moderate to severe ARDS. The delivery of invasive mechanical ventilation in the prone position is similar to supine position in terms of ventilatory settings. Patient during prone ventilation does not require additional monitoring, although the need for endotracheal sectioning should be assessed with increased frequency. Electrocardiographic leads should be placed on the back. We aspirate the feed prior to procedure and resume it once proning done. These patients may require increased sedation and/or neuromuscular blockade during prone position, and the optimal duration of prone positioning is unknown. Usually it is prolonged and varies between 18 to 20 consecutive hours in a single session. What can happen immediately after prone? Patients may develop transient hemodynamic instability and oxyhemoglobin desaturation immediately after prone position, and it can be minimized by providing adequate sedation and pre-oxygenating with a fraction of inspired oxygen of 1 prior to moving to the patient. Peak and plateau airway pressure may increase immediately but decline with time. The initial increase in the peak and the plateau pressure is likely related to decreased chest wall compliance and the mobilization of secretions, while the subsequent decrease is probably due to progressive alveolar recruitment. With regards to assessment of response of prone ventilation, it is considered when there is a sustained improvement in gas exchange, means rise in the PaO2 or partial pressure of oxygen more than 10 mm of mercury on stable ventilator settings, or evidence of alveolar recruitment, means increase in the lung compliance based on a fall in plateau pressure for a given tidal volume. Usually a response is noted during the first hour of the initial trial. The complications of prone ventilation includes increased need for sedation or paralysis, hypotension or arrhythmias, transient oxyhemoglobin desaturation, airway obstruction, vomiting, loss of venous access, and displacement of endotracheal tube, skin breakdown, dependent facial and ocular edema, and brachial plexus neuropathy. The frequency of pressure ulcer does not appear to be different with the prone ventilation, but rather occurs in a different locations such as the anterior shoulder, chest, knee, and face. So, to summarize, prone ventilation refers to the delivery of mechanical ventilation with the patient lying in the prone position. The prone position alters the mechanics and physiology of gas exchange, resulting in improved oxygenation and may result in improved mortality in select population of the patient with the severe ARDS. It is used as a rescue therapy in those who fail low tidal volume ventilation in the supine position in moderate to severe ARDS, means when PF ratio is less than 150 mm of mercury with FiO2 0.6 or more and PEEP 5 or more, or for refractory hypoxemia in ARDS provided there is no contraindication. It is applied early in the course, preferably within 24 to 36 hours for 18 to 20 consecutive hours. Here I finish. Thanks for watching this video. If you have any feedback, suggestions or comments, please write it down. Once again, thanks and see you in my next video, how to select oxygen therapy. Till then, bye and take care.